So good morning, everybody. We are gathered here today to continue our conversation about health and safety as it relates to opening our schools. And I'm going to ask people to introduce themselves. I will start. I'm Bonnie Birdsall. I'm the Director of Digital Learning and Communication for the Champlain Valley School District, and I am a member of the district's reopening team. Lisa, will you go next, please?
Good morning, I'm Lisa Bisbee. I'm a special educator at Williston Central School, and I'm the chief negotiator for the Champlain Valley Education Association.
Andre?
And she rocks too. So I'm Andre LaChance. I'm an English teacher at CVU. I've been here longer than Jean Jensen, which is a long time. And I'm glad to be here. Thanks for having me.
Yeah, thank you. Jean?
I'm Jean Jensen. I'm the Chief Operations Officer for the Champlain Valley School District, and I'm on the reopening team.
Thank you. Leah?
I'm Leah Costello. I'm a pediatrician at Timberlane Pediatrics and have been helping with consulting for the Champlain Valley School District for reopening.
Great. Jocelyn?
I'm Jocelyn Bouye. I'm one of the school nurses at Shelburne Community School, and I'm the COVID Health and Safety Coordinator for the CVSD district.
Terrific. Monica?
Hi, I'm Monica Ogilby. I'm a pediatric nurse practitioner, and I'm the Director of Children with Special Health Needs, which is a program at the health department. But since March, I've been one of the clinical leads for our contact tracing team out of the health department, and we'll talk a little bit more about what that means exactly in a few minutes.
Thank you. And Elizabeth?
Hi, good morning. I'm Elizabeth Hunt. I'm a community pediatrician and a CVSD parent.
Terrific. Thank you again, all of you, for joining us. I think I'm going to start with, and Monica, we might need to rely on you because of your role. Can you talk about what contact tracing is and what makes Vermont's approach unique from other states?
Sure. Contact tracing is the practice of identifying somebody who has a communicable or contagious virus or disease, identifying that person who is potentially a host, and identifying the other people that could be at risk of getting it. So that's a pretty broad explanation because we use contact tracing in a variety of ways and with a variety of different illnesses and diseases. So applied to COVID-19, we identify the person who has COVID-19, and we figure that out either because a provider in the community reports it to us, or we get a lab. So usually we get those lab results from all of the major labs that are processing these diagnostic tests. And then we reach out to that individual who's been diagnosed with COVID-19, and then we figure out who's been in their circle and who they've been in close contact with so that we can then reach out and support those individuals as well and provide them with guidance and answer their questions. I'm sure we'll go into greater detail about what that process looks like, but I think what makes Vermont's process so unique is, the contact tracing team that is doing this work are all health department employees right now. And so they have a deep vested interest in public health and public well-being. And they're a pretty tight-knit team. So we're able to really work and support with one another, work with and support one another, and to move quickly. So speed is really of the essence and time is of the essence here because we want to identify the person who has it. We want to identify their contacts and make sure everybody has the support that they need in order to follow the guidance. So I think our team-based approach is fantastic. We have excellent support from our leadership, and quite frankly, Vermonters and people that we've been in contact with have been great. And then I will also say that part of what makes our approach so unique is that we really do recognize that who we're talking to are humans that have lives and real things going on, and they have children they have to care for, or loved ones they have to care for, or jobs that they have to report to. And so we try to really recognize the humanity in this and make sure that if they need support with, rental assistance or transportation to get someone else in their contact list tested, if they're worried about housing security, if they're not in a safe housing situation, we make sure that they're connected to the resources they have. And in fact, in Vermont, we've actually established a an extra layer of support around our contact tracing team, where if there's somebody who really has need for support and coordination of care above and beyond what sort of we do through our standard contact tracing process, we connect those individuals that were on the phone to a care coordinator who can make sure that they can get connected to the resources that they need and follow up until that takes place.
Thank you. So what might it look like in schools, contact tracing?
Yeah, it's going to look in schools very similarly that it does out in the community. We also have a school team that provides a lot of support to the school and the administration themselves. So we've got the contact tracing team that does exactly what they do in every situation and scenario. And then we also have the school support team that's going to provide an added layer of support to the school and the administration. And that's not unusual. We have multiple teams that sort of float in orbit with the contact tracing team. And depending on what the scenario looks like, we deploy them to support the institution that needs support. So in this case, it would be a school. So if there was a person identified as having COVID-19 in a school, we would contact them or their guardian in the case of it being a minor. We would provide them guidance on isolation and what exactly that means. And then we would talk about who their close contacts have been in the past 48 hours. So for an individual who's tested for COVID-19, who does not have any symptoms at all, we do contact tracing 48 hours in advance of when they were tested. For a person who is symptomatic, so say they have a fever or they have a cough or they've had a loss of smell or a headache, we would actually do contact tracing 48 hours in advance of when those symptoms started. So when the symptomatic person gets tested is a little bit less relevant. But if not have symptoms, then we use their test date as kind of a proxy. So what we'll do is we'll contact that individual, find out who they've been in close contact with for the 48 hours prior to their test or the 48 hours prior to when their symptoms started. And then we'll create a list. And we spend a lot of time together having this conversation. We encourage them to look through their texts, look through their calendars, take their time, not rush the process. And we talk about what the guidance is going to be that we're going to provide to their contacts. We also talk about if they would like to reach out to their contacts in advance so that they can give them a heads up about their positive diagnosis and let them know we'll be calling. Otherwise, we never disclose the name or the information, any protected health information of the person who is the positive case. That would be a violation of HIPAA. So it's not unusual that people say I would rather not disclose that information, and so we maintain their privacy. And then we call all those contacts and provide them with quarantine guidance and make sure that they have the supports they need in order to get through their quarantine period.
When you contact the nurse or something at school, I mean, these kids will, at least CVU would be with 60 to 100 kids each day. It might even be it might be 200 kids that you're going to get names from, and 40 teachers and administrators. And I'm also wondering, does school close till you have alerted all those people, or are you asking all those people to stay at home till they get contacted again? So.
Those are really great questions. So we have to talk about what a close contact actually is here. So in order to be considered someone who's a close contact, you have to have spent more than 15 minutes within 6 feet of somebody who has COVID-19. So realistically, in the environment of physical distancing, that's not really that many people. So if you have a positive staff member or you have a positive student in school, what we are going to do is say, okay, within what we call their infectious period, and I use air quotes because, again, sometimes someone might not be contagious, they might not have symptoms, they might not actively be coughing, and so we're calling their infectious period 48 hours prior to when they got tested. They don't have symptoms. So we're going to say, okay, that kid got tested, or that student or that staff got tested on Monday. They didn't have symptoms. Who were they in close contact with Saturday, Sunday, Monday? So who were they within 6 feet of for greater than 15 minutes? So that's what's considered a close contact. So if you're passing someone regularly in a hallway, if you're outside of 6 feet distance with somebody, if you are in a classroom or in a space and you leave that space and then the infected person comes in, the case comes in, that's not considered contact. So we're actually seeing that because of the distancing practices and the intentional limiting of crossing, students and staff. We're seeing this in childcare and daycares that have been running all along. That the circle of contacts around a student or a staff member are actually pretty minimal.
So if a student, let's say, was COVID positive but didn't know it first block and was in a room for an hour and 20 minutes, and then the next group of students comes in, and I'm guessing the small particles are still in the room, and then next group comes in, no, they're not within 3 feet or 6 feet of the student, but they're in the room of somebody who has tested positive. So I don't quite get why they aren't notified or looked at. Or are you assuming we don't get COVID from being in a room or on
Well, what about the face coverings, Andre? I mean, do you feel like your students and coworkers at CVU will be covering their faces most of the time? Because that, it seems like, Monica, I don't want to take over, weighs in significantly, because that index positive person would presumptively, hopefully, have adequate coverage of the nose and mouth, which significantly decreases droplets leaving his or her body and remaining in that space. And that's air you're talking about. In terms of surfaces, Jean and the team are going to be, they're going to be wiping down particularly hard surfaces that are commonly contacted daily and throughout, as able.
I think they'll be wiping them at the end of the day, but we only have 5 minutes between classes right now. So I don't think you're going to get a well-wiped room in 5 minutes, especially when the teacher has to run to the next room or run to the bathroom even. And I would, I guess, add, and part of your list is have the student or the faculty member show you what mask they were wearing, because we know that the quality of the mask makes a difference. And if a student is in school with a bandana mask, then we're not as protected as we are with another mask.
Andre, this is Leah Costello. One of the other pieces that, as Jocelyn likes to put it, as your armor, kids who are ill aren't going to be at school. So the only person who could possibly be at school would be an asymptomatic person in there. And I think Monica would probably have more information on this, but you're not going to be having someone who's febrile, coughing in first block and really, spewing a lot of COVID into the air. But I bet Monica has some great answers to your really good questions.
Yeah, those are all great questions. So Elizabeth, did you have something to say?
No, and also it's good that we have you, Andre, from the older student population, and then Lisa, are you an elementary ed teacher?
I'm a middle level right now,
Okay.
and I'm a special educator. So one of my questions, which sort of ties to this, is how do you do contact tracing for an unreliable reporter, like a kindergartner or a student with special health needs who's nonverbal? Like, how do you do the contact tracing where they can't remember who they saw or whether they were wearing masks, all that sort of stuff? How do you keep track of that?
I'm going to make sure that I get back to the cloth facial covering and then answer that question, because that's a really good one. So, generally speaking, I think Leah's point was really important. We're not going to have symptomatic kids in school. So asymptomatic plus wearing cloth facial covering, the risk to other people, even those who are considered contacts, is really, really quite low. We also consider the thing like the nature of the contact. So if somebody kisses someone or shares food or drink, we would consider that a close contact, even if they're not, it doesn't take place for 15 full minutes and they're not within 6 feet of each other. So there's a little bit of common sense here, but those are all things that in a school setting, we don't allow kids to share food or drink anyway. I think that's where we're going to depend on guidance for schools. So we do use a little bit of judgment here when it comes to talking about the nature of a contact. But for people that are wearing a cloth facial covering, are asymptomatic, are within 6 feet for greater than 15 minutes, we're still considering the vast majority of those types of situations pretty low to medium risk when we're assessing risk for our contacts. To your point of entering a space that someone who's COVID-19 has been in, we're in a very different place now in August and certainly going into September than we were, say, back in March when people were coughing in big conference rooms. And people weren't being diligent about washing hands, and people weren't being diligent about creating some space between them and other bodies. Now, I know I have a rising kindergartner in the Harwood school system, so I'm very familiar with the challenges in encouraging kids to distance their bodies from others. But again, these kids aren't symptomatic. Hopefully they're wearing cloth facial coverings to the best of their ability and based on development. So there's a lot of things that are very different now than were in March. And we've been doing this in childcare settings and in summer camps all along. And we've been incredibly encouraged by the lack of transmission from any child who's shown up at a childcare to their peers or to any other staff. So that's really encouraging. Lisa, to your point about kids and reporting, that's where we're going to rely really heavily on schools to be thoughtful in how they're setting up the day and how kids are traveling and who they're spending time with. So, we're not going to rely on a kindergartner necessarily to be their primary reporter for their contacts. We're going to rely on their teacher. We're going to rely on their school nurse, whoever their team is. And just like if any of you have gone to a restaurant or an establishment, they've been asking for your name and your phone number for contact tracing purposes. We're going to rely on the schools as partners to say, okay, my kid's name is George. George was in kindergarten. He was in his classroom. He was, tested positive on Monday. We need to know who he was in close contact with in the school. So we're going to rely on the schools heavily for seating charts, things like that. But we'll talk through each one of those cases because truly it is so case specific. If you tell me kids are all running around on the playground together, and we don't think any of them spent greater than 15 minutes within 6 feet of one another, then it's highly unlikely that any of those kids are really at much risk.
Well, the only pushback I'll give you is the language that Dr. Costello also shared, that kids who won't come to school who are sick. In 30 years, I've seen plenty of kids who've come to school who are sick because they're on the soccer team and there's a game later that day. Mm-hmm. They're AP and they don't want to miss the lab. Their best friend is having a birthday that day. We are going to have kids who are going to fake their way or do something to get to school. So I would just change that language. There won't be many kids that will be there for sure, but we're not going to have a no situation.
And Andre, that's true. Huge because we have to, we know what we're doing and what we're talking about, but the kind of community peer pressure to just dumb it down for the few weeks before school, be cautious, no traveling ideally, and I think reinforcing to particularly our teens who've been living loose all summer that this is some serious, cow patties here. We gotta get serious if you want to be in school and see your friends and your awesome teachers, that you need to amp up your self-responsibility, and parents too need to really be serious about checking in with their kids, knowing their symptoms. I feel like even the biggest deniers of the pandemic don't want to be the ones to spread it or be home or miss work. And so of personal responsibility, which teenagers, don't really develop that till their 20s. But, in terms of just understanding that their symptoms are going to be checked every day. And I got to tell you, Andre, in healthcare, we also screen people, and people do very rarely get through the cracks. The thermometer is the hard stop. Like, we've had kids come for checkups where, you know, the parents are like, oh yeah, they've been great, they're awesome. And every so often they do have that low-grade fever, in which case they're, you know, turned away and not able to enter. So I think the 2 tiers of screening, which Jocelyn can speak to as staffing summer school all summer, with younger kids who don't transmit as actively as your over 10-year-olds, which is why the age groups are extremely important biologically. But you're right. Like, they want it right. They don't want to miss practice, or they don't want to miss like whatever event is happening in school. But that the 2 tiers, and also hopefully this whole Vermont Strong movement of like getting our acts together so we can open school, will be powerful enough to keep a very, very minute number from falling through the cracks.
And Andre, I just, from a school nurse perspective, this is a huge departure for us. We are usually the first ones like, you can do it, let's push through. And our job has always been to keep kids in school and help them. So we've been directed from Dr. Holmes and people at the state level that this is not the year for pushing kids through. And so it's a huge change for us mentally. Like, you know, any sign or symptom, kids are going home, no questions about it. And we are really working on educating parents about that, because I think that parents are going to want their kids in school if it's only 2 days a week to start. And like you said, they have all these other things that are kind of tied to being present in school. But it's not negotiable. And so we are really trying to help get our parents on board with that and understand that if you sacrifice one day, that might make the difference between having your entire school closed down. So like Elizabeth said, this is a whole community responsibility to keep our schools open.
Yeah, that sounds great. Are you going to be screening before each day at practice too, since kids won't be at school?
I did hear that, you know, CVU is unique because kids are it's possibly an open campus and kids are going to be coming and leaving. And so the Department of Health has said, yes, if you leave the building, you get rescreened. So if even as adults, if we went out into the community and got lunch somewhere, you should be rescreened. And whether that's going to be through the app, I'm not sure, but it might just be a kind of a checklist that the coach is running or the coordinator for the after school group. But yes, if you leave, you need to be rescreened.
So it wouldn't just be leaving, it would be like, let's say they're in school Monday, Tuesday, on Wednesday, Thursday, Friday, they have practice, but they're on distance learning, but they show up for practice. So
yes. Yep.
So I don't know how many thermometers we have going around, but
we got a lot.
Okay.
Yep. Yep. So yes, but absolutely, because that is definitely a place that we have to pay attention to. You know, sports teams could easily have close contact, so they will be screened as well.
Andre, Erin Carrick from our last video really described it as the Swiss cheese model, where each of the layers that we do has a hole in it, but if you line them up, still, a case is going to get through. Yes, there's going to probably be that perfect lineup, but that each layer that we put in really helps to block those holes and make them smaller. And I've just been loving that model and using it with my patients too to describe it. That and even actually the middle school principal from Heinsberg said, "Oh, I've been molding Swiss cheese all summer." Really thinking about each of these layers of protection that we have in place, and it doesn't make the risk zero. We know that, but certainly to lower that risk, and that health screening being one of that big first thick layer that we're putting down before all the other layers of socially distancing and washing our hands and wearing masks.
Leah, another layer to that Swiss cheese I wanted to add was, you know, that this isn't in any way to reduce the seriousness of positive result. For people who are getting results that are completely asymptomatic, they're really quite taken aback, especially if they've really been following a lot of the physical sort of been going about their daily life. We know that people test positive for months after having COVID-19. So it is not impossible that someone might test positive today that actually was infected a long time ago. And so when we talk to people about this, they're like, well, I had a terrible cough and a terrible cold. I was miserable in March and April. feel fine now. How could I possibly be positive now? There is we will never know the answer to this question, but there is a possibility that we are testing people positive that are not contagious or are not actively infectious. We're still going to take all the precautions. They are going to isolate. Their contacts are going to quarantine, and we are going to do that out of an abundance of caution. And hopefully their contacts go ahead and get tested as well. So, I think it's also important to recognize that we are really ramping up our testing efforts. We are aggressive about our contact tracing. We lock those cases down so fast. And people are incredibly, for the most part, really compliant with the guidance we're giving them. And they come back around sometimes as contacts again for somebody else. So we've talked to quite a few people multiple times during this pandemic. I actually had someone thank me for a recipe I gave them because I had to call them again. So I really mean it. We're here to help. So I think it's important to recognize that, there's a lot of layers of complexity to this that we are still unraveling as time goes on and as we get more guidance from the health department and the CDC and other experts.
Monica, I have a question for you. I'm wondering, what can the school do and what can families do to support contact tracing? What would make your life easier if we do and when we do have a positive case? What do you want us to know?
Answer your phones, please. Now is not the time to screen the call. If it says no caller ID, you pick up that phone. It could be me. I might have a great recipe for you. Plus I can help other people stay healthy. So no, answer your phone. Just answer your phone. Keep it charged. Keep it on you. That's number one. Number two is, now is not the time. I know it's the last few weeks of the summer. Say no to barbecues. Say no to travel. I know you love your grandparents. My kids love their grandparents. We're not seeing our grandparents. They're coming from a yellow and a red area. Now is not the time. What we do today impacts if our kids get to go to school in September. I can't stress how meaningful that is. Now, we see the aftermath of what happened 2 weeks ago on the contact tracing team, and we're like, oh, there's the 4th of July. Oh, there's Memorial Day. So let's make sure that we're being really diligent and even as strict as humanly possible right now about our actions. The other thing that you could be really that's helpful for us is keeping contact of who your contacts are. Anytime you're anywhere, this has turned into like an obsessive exercise for me. Anytime I'm doing anything, I think to myself, would I be a contact right now? Am I within 6 feet of anybody for greater than 15 minutes? Am I sharing food or drink with anybody? Am I, I really think about it. Would I be named as a contact right now in this environment? Or would any of these people be named as a contact of me in this environment? So I do that exercise obsessively all the time. And I do try to make note of people that have been contacts of mine. And the clock does reset. What I did a few weeks ago, 4 weeks ago, any close contacts I had, they're not positive. I'm not positive. The clock has reset. I don't need to really keep track of what I did a few months ago, or a few weeks ago. But it's really like, what are you doing in the past 14 days? So answer your phone, please, please, please. Keep track of your contacts and lock it down so our kids can go to school in September.
Do you, first of all, I did a COVID test, and I don't answer my phone when it's somebody I don't know. Is there any thought of just leaving a message to say, hey, this is the health department, give us a call back?
We do that.
Okay.
We tried, so the only time we won't do that is if you have a generic voicemail. So let's make that bullet number 4. Don't have a generic voicemail. So if you get the, hi, you've reached 802-555-55, we won't leave any information because it feels creepy, but I would hate to leave even just a, hi, this is a health department voicemail on someone's phone. It feels worrisome. So we tend to leave generic voicemail saying, hi, this is the health department. Please give us a call back at this number, option 3.
Okay.
Yeah, but we try to call you a few times before we resort to voicemail. And we also do email to text. So we'll text you, we send letters.
Okay. I have a question. How does sharing a single stall bathroom impact contact tracing? And for that matter, how would at CVU, they have the multiple stalls. Is that a point of contact? Is that a vector?
No, we would not consider anybody using a shared bathroom a close contact, unless they were in that bathroom stall together for greater than 15 minutes. I don't know.
Hopefully be rare.
Yeah, hopefully. I don't know. I was deeply uncool in high school, so I'm not sure. So that wouldn't be a concern for us. You know, when you have someone who is quarantining or isolating. So if you have a case who's isolating in their own household and sharing a bathroom with other people that are not positive, the recommendation is that you wipe surfaces down, just sort of out of an abundance of caution, because I don't think that we can say with certainty, you know, that you're not going to transmit it, but we would not consider that a contact.
Monica, can you get back to Andre's question? Because I'm really fascinated by the mask piece and what type of masks and the bandana, the single layer. I know that's not recommended, but
yeah. So, you know, I don't have the answers here. You know, there's a lot of research that's just coming out, and what we do know is that double layer tends to be more effective than single layer, which makes sense. And that there are some materials that are more porous than others. So like fleece, for example. So like those fleece balaclavas or those fleece gaiters that people tend to wear a lot. There's concern that those might not actually be effective or might actually worsen spreading. So I would, this is something we've been talking about a lot at the health department. And if you're on those calls with us, we discuss it a lot. I think the evidence is still sort of coming out. I mean, I would recommend that people wear a cloth facial covering that goes around their ears or around their head versus a bandana that's open in the bottom, if it can be tolerated based on development. I would say stay tuned for more information about that.
So Monica, just be clear that in our younger grades, we're going to have, say, a classroom that comfortably seats 22 kids is going to have maybe 9 and a teacher. And I think we're pretty confident at that size we can keep them 6 feet apart. But they will be, and we're doing our best, honestly doing our best with airflow, which, you know, I think will be really good for the first few months until it gets cold, in which case we're working with Efficiency Vermont to get some options in place for when it gets colder. But if there was a child whose, say, parent tested positive in that classroom, what would happen in that classroom? See, remember, these kids are together for 6.5 hours every day, 2 days, at least but now 2 days a week, potentially 5 days a week. So what would you consider that? What would be the contact tracing in that situation?
So the parent in that instance is the case. So we would call that parent. We would say, who are your close contacts? And that parent would have to isolate based on our guidance. And then all of their close contacts would have to quarantine. So in that instance, that presumably, if their kids were in their custody and with them, those kids would have to quarantine. So they wouldn't be allowed at school based on the quarantine guidance. There would be no impact for the other children or staff members that were in that classroom. We do not worry about contacts of contacts.
Good. Okay. And then what if the child was tested and did turn out to be positive, asymptomatic but positive? Would that? Yep.
So then that child who was previously a contact flips to a case. So we start all over. Mm-hmm. We say, okay, you know, the kid is now the case. Who were their close contacts? So we would work with the school and say, this kid was tested on this day. We need to know who their close contacts were for the 8 hours in advance. And so this is where schools being thoughtful about how many classrooms or pods of kids are interacting with one another is really critical. You know, I from just a practical standpoint, again, parent of a kindergartner, if there is a classroom of 9, 10, 15 kids all together every day for 6.5 hours a day, it's likely that if one of those kids is a case, that the other kids in that classroom, the vast majority of them might end up being contacts, just because of the nature of development and kids and interaction and socialization. And we have lots of reason to believe that most of those contacts won't matriculate into cases. We feel really, really strongly about that. Otherwise, we wouldn't be having this conversation. Mm-hmm. But, you know, the more you can limit the interactions from kids, say, outside of their classroom, certainly the better. It helps us kind of lock that down and isolate that much faster.
Right. And I think it's one of the upsides of having to be prepared to flip to fully remote in a bigger situation is that flipping those 9 kids to fully remote for their 2 weeks of quarantine may, and the teacher, of course, you know, may be easier than it would have been if we hadn't been preparing for fully remote anyway.
Absolutely.
You're definitely right, Jean. And I think that adds on to what Andre was saying, and that's kids not wanting to miss out. But the district being open and, I don't know, fluid with kids still being part of their classes, you know, ongoing. Almost all kids who we've seen with COVID aren't so sick that they couldn't learn from home. You know, they can still be engaged. Mm-hmm. They're not getting severe disease at all, even in other countries where they're, you know, on the other side of this. So I agree with you. I'm really happy about that. And I also think that AOE guidelines, the update, really looked at like 2 populations of folks who will need to be home. And this is just as true for teachers as it is for students. And those are symptomatic, ill. So people, because of likelihood of disease, need to be home. So they're either quarantining because of a family situation, or they're home because they are ill, in which case, remember, they interact then with the healthcare community and get in touch with their PCP about next steps, testing versus office visit versus symptomatic care. And then all of the contacts of positives are also expected to be home, right? So they were really more clear in the updated version. And I think that's going to be important. I have a friend who's a teacher, a middle school teacher, and he said, what if I'm not going to be able to teach, you know, in school if I'm positive. And so there will be classroom specific decisions, but I think the health department is totally prepared and willing and able to take those on with the school district. Like, it won't just be every school district has to figure it out on their own, because we can't have panic in one part of the state and laxity in another part of the state, right, Monica? We have to really like be super united with just calm, public health based, cautious action. And that's helped us in healthcare, you know, being kind of opened up for months now and seeing sick people and having unexpected interactions, which is sometimes frightening and makes you kind of step back. But I would say, granted, we're not in rooms with the same number of people for hours every day. I know you can't compare exactly. I don't want to insult any of the teachers here. It's different, apples and oranges. However, over time, we've, I think, done pretty well with our low number of positives in Vermont, and we're really having these conversations to build on that success.
And, you know, the one thing I'll say is we've been doing this all summer. You know, so we've had kids in childcare settings that have been positive. We've had staff members that have been childcare settings that are positive. And a lot of the times these are much smaller kids that are physically more dependent on adults. So these are kids that are having their diapers changed, that are being fed by the childcare providers. And it doesn't mean the whole center has to close down, not at all. It's, you know, if the childcare centers have, for the most part, been really thoughtful in their approach. And so, you know, the same staff are interacting with the same kids. And so maybe that one classroom that's pretty small and controlled in certain terms of numbers might have to stay home for a few weeks or follow the quarantine guidance. So quarantine for 7 days plus get a negative test, and then they can return to work and to school and to childcare. So it's not, in very few cases, and it's not normally a health department directed, it's usually a childcare center's decision, has anyone had to close. So we've actually been doing this for a while. We've had cases in camp, not a lot. We've had a few cases in childcares, but again, we've had quite a few months to prepare for this.
Monica, I have a question for you. It's more logistical. So back to the kind of the class that had the kid who became a contact or who became positive.
Mhm.
Now, does that person have to get a test, or what if a person chooses not to get a test? What happens? What's the guidelines? Is it a 14-day quarantine if you don't get a test, or can you talk me through that?
Sure. So the guidance for people who are contacts of a positive case is that, first of all, you have to figure out the last day you were in close contact with them. So the last day you were in close contact with them is day 0. Then your clock starts. And you can either quarantine, so contacts quarantine, cases isolate, just to make things a little more confusing. So the contacts quarantine for a full 14 days. So the last day that you're in contact with the case is day 0. And then you've got to quarantine for 14 full days. Or after day 7, you can get tested. If that test comes back negative, then you can end your quarantine early. The only stipulation there is if you develop symptoms during that period, we're going to recommend that you contact your primary care provider. And if you don't have a primary care provider, we will help connect you to one. Because if those symptoms are related to COVID, then the guidance might look a little bit different.
What if
So
somebody...
Monica, I was going to say, as a parent of also a rising kindergartner and a 3rd grader, say my child is, I find out that he is a contact and needs to isolate. Clearly, my children cannot care for themselves at home. So what would be myself as a parent, what would be your recommendations to me?
Give them an iPad and a box of cheddar bunnies and call it good.
Do I have to say
I'm kidding.
Yeah. But I already do that, and they're not even contacts.
I know.
Yeah.
They're still there all the time, needing things. So you are not named as a contact there. So you technically, as the parent of a contact, do not need to quarantine with your children. What we recommend there is, imagine your kid has the stomach bug, right? You don't want that stomach bug. I'm not comparing the coronavirus to a stomach bug, but you don't want that stomach bug. So you're going to wash your hands a ton. You're going to be extra diligent about household hygiene and cleaning. You're going to wipe down surfaces. You're going to probably do a few extra loads of laundry. You don't need to quarantine with your children. Obviously, based on development, you might need to stay home with them. But if there's someone else who can care for them, a co-parent or, older sibling safe enough to stay with them, you don't have to be locked down to your house like somebody else who's quarantined. So your child, the contact, needs to quarantine and stay home. But you yourself can still go about in the community as long as you're being really diligent about hygiene.
And then clearly, if my child got symptoms, that would start that all over again. And
yeah, if your child got symptoms and based on your judgment or the judgment of their clinical provider, you felt like it was in their best interest to get tested, then you, out of an abundance of caution, I would recommend if it were me, I would probably just hang tight and quarantine and get tested with my kid just to make sure.
What if somebody feels that they are a contact, but they haven't been identified as such?
I'm so glad you asked that question because it happens all the time. People say, I'm pretty sure I was in contact with somebody who's COVID-19, but nobody ever called me. Nobody ever talked to me. So we encourage them to call the health department. Call the health department. Let's talk it through. Let's talk through the cases. We can't provide any protected health information about the person that they're stating was a contact. And sometimes we might not even know that. If it was an out-of-state contact, we might not have access to that information. So we can still provide them guidance on what to do and how to quarantine if they are a contact of a case. We can also, many times people call us and we're able to sort of talk them down a little bit and say, it sounds like what you're describing isn't actually a contact. You really don't need to worry. That happens a lot in workplace settings. So essential workers that are still working, grocery stores and things like that. We get a lot of calls from employees of people who are say, yeah, but I work there. And if they weren't actually in close contact, they don't need to quarantine. And we haven't really seen any negative outcomes for them because of that.
Along those lines, Monica, how soon would people be contacted if they were if they heard about a case and they're wondering if they're going to be contacted, when would they expect a call?
Yeah. So there's a little bit of variability there, and there's a lot of factors that go into what the timeline looks like. And that's why just acting out of an abundance of caution all the time is absolutely critical. And I can't say that enough. So generally speaking, here in Vermont, if you're tested here in Vermont, especially at one of the VDH, the Vermont Department of Health pop-up sites, people get a phone call and a letter with their results. The phone call has been between 24, 48 hours from the health department pop-up sites. Occasionally, it's a little bit longer than that because we have a high volume of tests to process. So playing that scenario out, we get your lab results in 24, 48 hours. We're contacting you right away, contacting your contacts right away. So providing everybody answers their phone, provides us with the accurate information. Usually we have most of these cases closed within a day of receiving the lab result. But remember that from the time you get tested to the time we get the result, you are expected to be quarantining. So theoretically, you shouldn't have any additional contacts from the second you get tested, theoretically. And most people are really good at following those directions. But that's why just always being super careful about your behavior is important because, again, we want our kids to get back to school. So if the rest of us can chill on the socialization, that would be really helpful. If you get tested at some of the urgent care centers, they're sending their tests out of state to diagnostic labs that might take longer to get results back. We've heard as long as 7 to 10 days. So it depends on who tests you, where they're sending their labs. And all of that has an impact on when we get the result and when we can do contact tracing. The other really interesting factor there is if you as a Vermonter travel out of state and you are in contact with somebody and you are named as a contact of a case out of state, then that out of state health department will do contact tracing with their case in their state. They'll say, Monica was a contact of mine, but she lives in Vermont. They'll fax some information to the state of Vermont, and then the state of Vermont will actually contact trace the Vermont contacts. Wow. All that is to say, don't travel out of state. Don't travel out of state if you don't have to. And also recognize that it is not impossible to get a phone call 10 days after you've done something and be told that you're a contact. And then you kind of go, but it's been 10 days. What am I supposed to do? So these are happening less and less and less because people are being really much smarter and thoughtful about their movement about in society. But it does happen. But generally speaking, in Vermont, if you are a Vermonter and you get tested at one of the VDH sites, you get tested at one of the hospital testing sites, we get the results really fast and you get the results fast too.
So can I go with the testing for a second? So I go to not me, let's say an athlete, which I think is going to be the biggest pushback. So an athlete gets tested by a school nurse, low grade fever, you got to go home. Next day, low grade fever, you got to go home. That family, that team, that coach, they're all going to want to test. They're going to want that athlete tested, not to wait for when that fever goes down. So how accessible, I just don't want people to be harassing my school nurses because, hey, our thermometer shows that they're fine. And is the testing available for that kind of situation?
Yes. I mean, I would also ask Elizabeth and Leah, who have probably been inundated with phone calls for testing. But certainly if we've got the pop-ups that are all over the place. There's a lot of really great resources that are available for testing. It's all on the health department website, but there's a lot of pharmacies now that are starting to offer testing. But also if you're symptomatic, you just have to call your provider. Elizabeth.
Yes. So that is a situation that I'm sure will come up, Andre, right? Because what you're describing is a situation where this young person is not overtly ill. Because I'm assuming by low grade, you mean they're under 100.4. If they were prompted to see the school nurse because of
not feeling well, then that in and of itself is like an admission of some illness, right? You're run down. Fatigue. We're totally seeing fatigue in especially adolescents with COVID. Aches, weakness, those kind of things. And so then it is incumbent upon the school nurse to kind of take the recommendation to seek medical care, in which case, if a Vermonter has signs of illness, they can get away with not getting tested, but they have to quarantine for 2 weeks. And the school nurse would be well, I don't know how much tracking, I don't want to speak for you, Jocelyn, but would be aware of those students who have been diagnosed with illness. If they then present to Dr. Costello or myself, then we're trying to keep like a week to week, day to day kind of finger on the pulse of testing availability and timelines in Chittenden County and beyond, because it comes to our attention all the time. And Monica, I'll tell you that it's been really nice to have CVS pharmacies, Walmart, these sector large companies get involved. Most of them will not test children, and none of them will test under age 2. I've just had that confirmed. The turnaround for results is 7 to 10 days for the Vermont participating pharmacies, just as of the end of last week. So unfortunately, that doesn't give us the right information for that index student, right, to re-enter. And to my eye, quarantining looks like the path of least resistance in that case. There are times when, Andre, we do identify a clear cause for illness. Like I've seen a ton of mono this summer. I've seen hand, foot, and mouth, things that really make sense, in which case we make a medical diagnosis that is not COVID-19, and then provide, I would say, fairly conservative education for the patient and the family in terms of when to ramp up activity. And usually that involves some follow-up on our part to make sure it's really responsible decision-making. And then in the case where a test is ordered, we would take care of that. And then we're really waiting for the test scheduling and then the result, in which case the ill student needs to be home for the duration of that time period. And so that communication is really between the student, their family, and the educational system, but also the healthcare system. And the state of Vermont Department of Health wouldn't really need to be involved in that kind of a situation. But getting a test that's negative that then gives them the green light to re-enter takes almost as long right now as a full 14 days of quarantine. And the time is our friend. It helps so much. I mean, the transmissibility of the virus after over a week is like way down. So these testing delays might end up kind of helping us in the long run in terms of having people be home. And I don't think in the fall it's going to get a ton better. It still takes days to get a result. Leah, did
Andre, I was going to hope this helps provide a little reassurance, Andre, that we are currently working on guidelines for return to school. And you are right, parents are they're going to be upset. They're going to want their kid at that soccer game. And you're so right. That's probably going to be the most challenging thing for parents and kids is, and then for the younger parents, like wanting to go back to work, obviously, but we are going to have very strict return to school guidelines that will be shared amongst all physicians and then also all school nurses based on the pre-test probability that the child may have COVID.
And on piggybacking on that, Andre, one of the nice things about our health screening app that we're going to go with is that if you go home sick or if you are identified as sick, you kind of get put in the red X box until your school nurse goes through and figures out why did you screen negative, what happened, did you have a fever, did you have a cough, so the school nurse will be reaching out kind of a little bit like contact tracing, finding out what happened there, and then only the school nurse will go through that algorithm from the Department of Health about return. They're going to tell us exactly when you can return, and then they can kind of green light you and put you back in the system. So if that student goes home, they're going to kind of get put in in that limbo place until they get cleared to come back. So that kind of prevents that person slipping back in the door, which we know happens in a normal year.
I have a different question. What at the state level is happening with monitoring the data that's coming in and making decisions at a state level? Is it happening? Is there a team of pediatricians and or health department contact tracers? Like what happens? What are the metrics that give us that alert? Like now it's getting serious and we might need to do something different. And who's on that team and what are the decisions being made?
I could take that one. So between Dan French and Commissioner Levine, working together kind of at the leadership level, they're looking at a few trends in Vermont over time, right, to guide decision making. And the kind of public health and education overlap, I think they have meetings about this kind of thing, but all of it comes down to what phase we're in. So we're in phase 2 right now. Are you familiar with those, Lisa? Yeah, so right now, like for athletics, right, we're considering ourselves in phase 3, which is why they're going to do practices only. And then when things are more reassuring, they'll consider like interscholastic play with, I don't know about the transportation piece, but anyhow, and then phase 1 would mean things are clinically much more significant and we would need to all be safe at home. More people would need to be safe at home in the state of Vermont. And so the AOE publication I referred to earlier is really going to be, they named, I think, 4 metrics that they're going to really have eyes on in the coming weeks. And that is reports of influenza-like illness. We call that ILI. So many people have viral illness, usually as it starts to get cold, but they're looking at numbers of people and trends in influenza-like illness, because those would be people who either don't get tested or don't want to get tested, but there's just more illness in the community across the lifespan. They're looking at COVID positive tests, obviously. So they're looking at positive tests, and then they're looking at Monica, okay, I do need you to help me. There were some other variables. I think it was people presenting for tests they're looking at, right?
Presenting for tests.
Presenting for tests, and then there was one other thing they're going to be following, and this is where that 2-week, right, the turnaround and shift towards the educational models and recommendations are based on looking at those trends.
Okay.
Yep. Thank you both. Thank you all. It was really helpful.
So nice to meet you. It's exciting.
We thought this one was going to be shorter, and we had so much good information again. Monica, that was really helpful. Like even just for my own practice to be able to provide so much more clarity on the contact tracing. So
happy to help.
See, I think the way that we need to end this is, as Monica pointed out so many times during this conversation, is that the couple of weeks before school, we really as a community need to be responsible and make responsible decisions, because we value our kids in school. And if we can all be safe in our movements and our actions, we can put the teachers in a safer position to go back into schools. We can put kids in a safer position, and we can put our families in a safer position, and we can get these kids to school safely. So please be responsible.
Great. Thank you, everybody. We really appreciate your time and knowledge and expertise and passion about this.